Okay, madam, you can start.
Okay. Okay. So good evening to you all. As you know, the registrars, we are conducting this session regarding a discussion on the real case scenario that we have managed. So at our family medical clinic in Panadura. So it's you as juniors since to practice the best evidence-based medicine, and as well as to it's a very good learning opportunity to share the knowledge among your colleagues. So I am conducting this on Thursdays, but unfortunately due to some unavoidable reason of mine, so I had to postpone to today. So it's apologizing for that, and I am asking my registrar, Suboda, Dr. Suboda will present this discussion case program to you, and Dr. As the trainer, I'm Dr. Malkanthi Galhina, as well as our acting consultant, Dr. Pasana, also here joining with you all to participate for the discussion to make it fruitful. And the other thing is we are conducting this on behalf of our college, Sri Lanka College of Specialist Family Physicians. So I hope that you will get some improvement of your knowledge, and as well as you will increase your skills with the sharing this discussion tonight. So I wish you all the very best. So please join. It's the Dr. Suboda. It's over to you. Now you can start the case.
Thank you, madam, for your kind introduction. I am Dr. Suboda. Good evening, everyone. As madam said, this is a real case I encountered at Base Hospital, Panadura, our family medical unit. I started my case presentation first. Mrs. A, 37 years old. She was presented, her presenting complaint was left side heel pain since 3 months and lethargy, increased sleepiness, and cold intolerance in 6-month duration. That her heel pain was gradual onset of aching type of pain, which starts with footsteps in the morning and resolved with walking. It was aggravated with prolonged standing, and pain worsens towards the end of the day. And there were no morning stiffness, no pain, no swelling in any other joints, no skin rashes over the body. And but she had a past history of accidental injury to left side ankle joint 3 years ago. And she had symptoms of lethargy, increased sleepiness, and cold intolerance. And recently she has gained weight 8 kilograms the last 1 year duration, but no history of constipation, no evening pyrexia or night sweats, no metabolic symptoms such as polyuria or polydipsia. And her last regular menstrual period was 30th of October. And she had initially regular 28-day cycles, which lasted for 3 to 4 days with normal menstrual flow. But since 1 year, she had experienced oligomenorrhea. She had periods regular, but lasting only for 1 to 2 days. In psychosocial history, she had no low mood, no lack of sleep, no loss of interest in previously pleasurable activities, and she was a non-smoker and non-alcoholic. Then I inquired about the eyes. The idea was she thought all her problems are related to her accident, which occurred 3 years ago. And she was concerned because she was unable to engage in her job, household activities, and caring of her children. And her expectation was to know whether she's having any serious disease. In past medical history, she had recently treated for pyelonephritis, and but no past history of rheumatoid arthritis, connective tissue disease, or hypothyroidism, or any non-communicable disease like diabetes, hypertension, or dyslipidemia. No past psychiatric illnesses or suicidal attempts. In past surgical history, she had underwent an accidental fallen 3 years ago. At that time, X-ray was taken, but no fractures, according to her. And she was on combined oral contraceptive pill since 2 years, but not on long-term NSAID or steroids. And she has no allergy and no family history of hypothyroidism or hyperthyroidism, connective tissue disease, rheumatoid arthritis, or any diabetes, hypertension, dyslipidemia, or obesity. In social history, her mother has died following suicide when she was 2 years old, and she is the only child in the family. After mother's death, she had looked after by maternal grandparents. Now she is working as a sales executive at a private company, and legally separated from her first marriage husband due to some psychiatric disease, and having 2 sons aged of 16 years and 12 years. And second time married 4 years ago and having 2.5 years old son. Both all 3 sons are living with her, and she had good family, good support from husband and also from mother-in-law. Then I inquired about dietary history also. She had mainly high-calorie diet, and this I have mentioned that her 24-hour dietary recall, and it's also, you can see she had taken more amount of starch mainly, and also she got snacks and sometimes taken outside food also. And regarding exercises, initially she had some walking during her field visit during job, but recently she had not engaged in any physical exercises. On examination, anthropometric measurements were weight was 62 kilograms and height was 148.5 centimeter, and her BMI was 28.1 and kilogram per square meter. It was under the obesity class 1 category, and waist circumference was 34 inches. It is 86.36 in centimeters, and she was obese, afebrile, no fellow, mild thin hair was there, and no clinical features suggestive of thyroid phases. Acanthocytes like decrease were there. Thyroid gland examination, no smooth enlargement of palpable nodules, no tremors of bilateral hands, no certiforms, no palm erythema, no tibial myxedema. Also, when examining her mental state, she was in pleasant mood. Otherwise, normal examination findings. Cardiovascular system examination, pulse rate was 84 beats per minute, good volume, regular. Blood pressure was 110/75, and dual rhythm, no murmurs. And respiratory system examination, respiratory rate was 14 beats per minute, vesicular breathing, bilateral INT was equal and no added sounds. And abdominal examination also unremarkable, no hepatosplenomegaly. And CNS examination, no psoas in the ankle or knee reflexes, and tone power normal in bilateral upper limb and lower limb. And musculoskeletal system examination, left side ankle joint examination, I noted tenderness at the heel anteromedial to the calcaneus bone, but no clinical signs suggestive of Achilles tendinitis. Right side ankle joint examination was normal, but no swelling of any other joints, no tenderness over any other joints. There were 3 main problems I identified with my trainer. And first one was left side plantar fasciitis. and second one was obesity, and third one we have to investigate further due to symptoms of hypothyroidism. In management, first we counseling done on diet and exercises, and also she was educated on emphasized on monthly weight monitoring, and she was prepared from OPD, and so she had came with some investigation reports at that time. Her ESR and rheumatoid factor was normal, and X-ray left side ankle joint taken, and no fractures were there. And then we planned investigations to find out the cause. We arranged thyroid stimulation hormone test, and for screening for non-clinical diseases, arrange fasting blood sugar, lipid profile, and liver function test. And non-pharmacological management, mainly for plantar fasciitis, advised to soak in the healing salt and water, and also stretching exercises. She was very afraid and sick. She was concerned as she got accidental fallen 3 years ago, and whether it is related to his ongoing left side heel pain. And then we took the X-ray left side ankle joint, then there were no fractures. Then we explained the patient there is no fractures, and then she can go with the physiotherapy. And then she also very thankful for us, and her fear was resolved. And as pharmacological management, she was given paracetamol 1 gram TDS for 3 days, and then planned to arrange a steroid injection. And she was asked to come with fasting blood sugar report in 3 to 4 days. With this case presentation.
No, shall I disturb you? In the middle of
yes,
the whole case scenario, because she believes that is due to her accident previously happened. This layer, the foot pain is coming, but instead we really, corrected her, the belief, and the convinced her that it's not because of that, it's because of her, the bad, the lifestyle, and as well as the poor eating, and the outcome was obesity. So where we clearly mention her, right, the correct thing that relates to this problem, because we need to take her into the path of weight reduction by telling her that problem is arise due to this obesity. Obesity is the problem where you are getting lot of, the medical issues as well as psychological issues. So because of that, we, being the primary care physician and the specialist in primary care in future, now you have to get the training to identify the opportunistic, the problems that patient will be, the deceased with that, not now, but in future. So that skill you need to have to identify the opportunistic, to identify any health related, the risks in future, and need to address those now. So this is the case, that is what we are really focused from this case scenario, right? Not just the management of plantar fasciitis. Management of plantar fasciitis as a early risk of the obesity, but there are more severe risks like NCDs, and as well as the malignancies, and some OAs of knee joints and all will be in future. So we have to tell the patient by taking that opportunity to, prevent the obesity, to treat the obesity and prevent ongoing obesity for this patient. So because of that, we, the thought of discussing this case scenario with you all. So now, again, I'll hand over to go to the discussion to registrar. Okay, Dr. Suboda.
Thank you, madam.
Okay.
Then I will start with give some educative on obesity. As obesity, we all know it is defined as accumulation of excess fat in the body, which is associated with adverse health outcomes. It is a complex metabolic disease resulting from interaction of a wide variety of hereditary and environmental factors. It has become a global problem affecting all societies and groups. There is increased prevalence of obesity among adults, adolescents, and children in developed as well as developing countries. When considering epidemiology, according to WHO, 39% of adults over 18 years are overweight and 13% are obese in year 2014. The increased rates are observed especially in the Middle East, Pacific Islands, China, and Southeast Asia. The epidemic of obesity has spread rapidly throughout the Southeast Asian region. According to Sri Lankan data, it also shows prevalence has increased in Sri Lanka also. According to 2010 data, it was reported as overweight of 25.2% and obesity 9.2% respectively. Then we will look about the pathophysiology. Obesity mainly due to increased energy intake and reduced energy expenditure. Increased appetite and increased food consumption lead to obesity, and increased excess fat, increased oxidative stress also contribute, and increased appetite and food consumption and reduced downregulation of thyroid utilization lead to increased adipocytes. And then cytokine release increase and hyperlipidemia and cause obesity. And adipocyte release leptin. Leptin is actually it is leptin cause induce anorexia, reduce appetite, and induce lipolysis, reduce lipogenesis, and cause reduction of obesity basically. And some patients there is leptin deficiency. More than deficiency, some people have leptin resistance, and that's lead to obesity. And pancreas, when considering pancreas, due to insulin resistant, it's when there is insulin resistance, it lead to decreased feeling of satiety and leading to obesity. And there are some hormones secreted by GI tract, such as cholecystokinin, glucagon-like peptide 1, GLP-1, and peptide YY36. These three are induce satiety and cause weight loss. But if there is deficiency, then cause obesity. And ghrelin induce appetite and cause obesity. Then we will see the classification of obesity. It is basically according to BMI, body mass index. Usually data is available to the Caucasians, and now Asian classification has modified according for the Asian peoples also. That values are taken for the Sri Lankan people also. This is from the College of Endocrinology Guideline on Obesity 2015. When I will go through the Sri Lankan classification. And underweight is considered as less than 18.5, and 18.5 to 22.9 is considered as normal BMI, and overweight is 23 to 24.9, and obesity class 1, 25 to 30, and obesity class 2, 30 to 35, and obesity class 3, more than 35. It is more than 14 Caucasians. all values are Asian. For Asian people, these values are lower than the Caucasian people. And when considering waist circumference, it is also bigger from Caucasians. For Sri Lankans, it is less than 90 and Caucasians 102. And for female, it is more than 80 for Sri Lankan and Caucasians more than 88 centimeter. This is because in Asians, the distribution of body fat is as important as the BMI itself. It has been shown that abdominal obesity is higher among Asians than Caucasians for a given BMI. Therefore, Asians develop obesity-related complications at the lower BMI. Additionally, Sri Lankan adults have been found to develop obesity-related cardiovascular disease at a lower BMI and waist circumference. So you can see at a low BMI and high waist circumference, we can see detect a lot of complications in our people. And this is some account of causes and associations of obesity. As I said in the previous slides, there are a lot of causes for obesity. And when considering environmental causes, it is due to excess calorie intake and physical inactivity. Some genetic causes also play a role. And monogenic causes like leptin deficiency or resistance, melanocortin or receptor mutation, and chromosomal rearrangement also cause, such as Prader-Willi syndrome, Lawrence-Moon-Beetle syndrome. And polygenic ones are, there are large number of human genes show variations in DNA sequences that might contribute to obesity. These are the common variant. And other secondary causes are Cushing syndrome, hypothyroidism, hypothalamic lesions, polycystic ovarian syndrome, and sometimes drugs cause obesity, steroids, antipsychotics, and OCP. And as Madam said, there are a lot of comorbidities and complications related to obesity. This slide, you can see system-wise, they have given some account. And regarding endocrine and metabolic diseases, there are metabolic syndrome, dyslipidemia, and cardiovascular diseases, hypertension, coronary heart disease, cerebrovascular and thromboembolic disease can cause due to obesity, and respiratory diseases like restrictive lung disease, obesity, hypoventilation syndrome, OSA, and gastrointestinal disease, GORD, gallstones, pancreatitis, liver disease can cause, and also neurological diseases, stroke, idiopathic intracranial hypertension, and in women, regarding to relevant to genitourinary disease, there are polycystic ovarian disease, and women can end up with pregnancy-related complications, and also urinary incontinence, and musculoskeletal diseases like gout, osteoarthritis mainly, and also malignancies can be associated, such as esophagus, breast, colon, rectum, liver, gallbladder, pancreas, kidney, multiple myeloma, and non-Hodgkin lymphoma. As Madam said, there are common diseases which can see in our day-to-day practice at our family medical clinics. They are usually type 2 diabetes mellitus, hypertension, dyslipidemia, fatty liver disease, osteoarthritis, obstructive sleep apnea, and in this case also plantar fasciitis we can see. When we come across obese patient, we have to assess the patient first. Then we have to take history and then physical examination and basic investigations. In history, we have to take birth history from birth, weight history from birth onwards, and also eating habits we can take a 24-hour dietary recall-like thing or food diary. And then I have to ask about triggers for eating and physical activity, psychological aspect of eating behavior, and then assessment of patient's motivation and readiness for change and expectation. And also have to assess in the presence of any obesity-related complications, such as cardiovascular disease, diabetes, hypertension, and other complications. And also have to assess coexistent cardiovascular risk factors, such as smoking, family history of diabetes, and have to inquire about drug history, as it is said, there can be antidepressant, antipsychotics, antiepileptics, and steroids. And also, as genetic syndromes can cause obesity, we have to ask about family history of obesity. And then with asking about rates of the partner or children, we can get a clue on shared dietary habits and lifestyle. And then I have to ask about previous treatment and management strategies and their success, which are taken for the obesity. And then I have to go with the examination. Then have to take correct anthropometric measurements, mainly weight, height, and waist circumference, and look for any features of insulin resistance, such as acanthosis nigricans, skin tags, and features of any underlying disease and associated conditions. So, as example, bradycardia in hypothyroidism and purple striatum Cushing's syndrome, like that. And presence of complications, I would check blood pressure, whether it is elevated. And in hypertriglyceridemia, you can see eruptive xanthoma. And osteoarthritis, knee joints, mainly selene and crepitus may be there. And we have to order basic investigation to screen for NCD, mainly fasting blood sugar, lipid profile, liver function test, and serum electrolyte. And if you are suspecting any specific cause, then have to arrange investigations also, TSH or any overnight dexamethasone suppression test. This is some guide to 24-hour dietary recall form. You can mention time and then mention what has eaten for the morning, breakfast, lunch, evening. Likewise, can take a small summary of the diet for 24 hours. And when I'm going to the management of overweight and obesity, after the anthropometric measurements, we can classify the BMI according to the specifications. And then if it is according to this guideline, this is national guideline for Sri Lanka to management of overweight and obesity. And if the BMI is normal or normal, then it's have to maintain the weight at the normal range. Only advices we can use advices. And if patient is under overweight, then I have to assess for any risk factors or comorbidities. If they are absent, then we can manage at primary healthcare setting. And this normal group and overweight without risk factors, then have to avoid weight gain. Then advise to lose weight if BMI more than 25, and have to treat if there are other risk factors. And these patients can be assessed 3 to 6 months. If there is improvement, then I have to see whether risk factors present. If risk factors present, review in 3 to 6 months. If no risk factors, then annual revival is enough. And if there is no improvement in weight loss, then I have to refer for nutrition clinic. And if with the nutrition clinic follow-up also, if there's no improvement, then have to refer for specialized clinic like endocrinology clinic. And overweight with risk factors and obesity class 1 people have to refer for according to that guideline, they guide to refer to specialized clinic first, and then look for secondary causes and arrange investigations. And if present, then manage accordingly. And if no secondary causes are identified, then have to manage with high intensity comprehensive lifestyle interventions and refer to nutrition clinic and surgical clinic if necessary. And when 5% weight loss in 6 months is achieved, then can review in 3 to 6 months, and if 3 to 6 months, or if no risk factors and control, then review annually. But if there is no 5% weight loss in 6 months, then have to intensive behavior treatment and reassess and address the medical problems and re-evaluate treatment protocol and continue management. As per family physicians, we can generally give advices on diet. These are some things you can educate the patients regarding the diet. Initially, weight loss target should be 0.5 to 1 kilogram per week, and then have to encourage to intake of vegetables, fruits, whole grains, pulses, fish, lean meat, poultry, and low-fat dairy products. And the intake of sugar sweetened drinks such as fruit juices with added sugar, soft drinks, energy drinks, and alcoholic drinks should be avoided. Also, when purchasing bottle or packaged beverages, we can advise to look for the traffic light label. By nowadays, at most of the bottles, they are given the green, yellow, red color label guide is there, and advise patient to reduce unnecessary snacking and large portion sizes also, and encourage to choose fiber-rich whole grains, less polished grains for most of the grain savings, and encourage to include fish containing omega-3 fatty acids such as sardines, salaya, hurulla, kumbalawa, salmon, mackerel, and tuna, and restrict foods containing saturated fats such as red meat, cheese, and whole fat dairy products. And also advise to take unsaturated fats such as fish, nuts, seeds, avocado, and olive oil, and educate regarding healthy cooking methods, and prepare more fish salads along with vegetables to minimize loss of nutrition and reduce the amount of thick coconut milk used for cooking, and use alternative cooking methods such as steaming, is a tablet-like thing, and restrict deep frying, heating oil to very high temperatures. And if deep frying is needed, then can encourage to use other options such as baking and using an air fryer. And also, some people go with the keto diet and 16-hour fasting, like unstructured and unsupervised diet plans, but it should be under supervision. It is, some methods are okay, but usually it should be supervision, and if it is going for more duration, it will result more risk than benefits. So I have to educate the patients regarding that also. And this is high intensity comprehensive lifestyle interventions, which is given for obesity class 2 and 3 people. It is basically a balanced low calorie diet. Mainly portion control is their portion is controlled in this diet, and exercises also they have mentioned, and behavioral therapy. And this is the normal, when we go through the food plate, which should be used for the normal BMI people. This is the given in the guideline, and normal BMI people, half of the plate should be grains and tubers, and from other half, 2/3 should be vegetables and salads, and only 1/3 is containing proteins, which is animal protein and plant proteins. when go with the plate model for modified plate model recommended for overweight and obesity, there is only a quarter of the grains and tubers we can consume for advice to take for that people, and quarter should be protein, animal and plant protein, and half of the plate should be filled with the vegetables. The vegetables should be not starch vegetables like pumpkin or any beetroot like thing. It should be green vegetables. It's better, and we can add salad, half a cup, and for snacks we then can take low fat milk, glass of milk without sugar, and can take two types of fruits per day, and also one tea or plain tea without sugar. This is the to give some idea for you. This is the recommended number of daily servings to a person with normal BMI. You can follow this later. And this is the calorie values of the commonly consumed food products on select foods on your daily calorie needs. It's containing how much 1 tablespoon of cooked dal is 25 calorie. This is also you can take some guide when indicating your patients. And this is sample menu of reduced energy diet. And basically, reduced energy diet, it's 500 kilocalorie deficit diet is mainly recommended. As example, if the patient is taking morning tea, taking full cream milk tea, 1 cup with sugar, 3 tablespoons, we can convert into non-fat milk tea, 1 cup without sugar. And likewise, this is give some idea. And if when considering lunch, rice 2.5 cups, usual diet is given in this slide is rice 2.5 cups, curry is 1 tablespoon from each fish piece. Then it can cut down to rice 1.5 cups, 60 grams of fish, 3 tablespoons of kohila curry, 3 tablespoons of mukunu mellum like that. And this is some example of reduced energy diet. And also weight reduction is one of main part in the obesity management. How to achieve 5 to 10% weight loss at the initial stage, and then achieve a satisfactory weight loss according to the initial BMI. It is mainly for prevention of obesity-related metabolic complications, and also improving overall health through optimal nutrition. And once weight maintenance, once the weight reduction goal is achieved, then have to maintain the weight around normal BMI. It's also very important. And we can, as example, we have this is monthly weight monitoring, some guide to monthly weight monitoring. We should emphasize the patient to get the monthly weight monitoring done. If example, if patient's initial body weight is 70 kilograms, then after first month, his weight should be 68, and second month 66, and third month 64. This 1 kilogram per 2 weeks is and 0.5 gram, 500 grams per week. And also physical activity is very important in the management of overweight and obesity. And main role of exercise is the prevention of weight regain rather than causing weight loss. It says to lose 500 grams in obese person has to run 7 kilometers every day for a week, or consume 500 kilocalorie per day energy deficit diet for a week. Benefits of exercises are a lot. It is It's cause modest contribution to weight loss in overweight and obese adults, may reduce abdominal fat, increase cardiorespiratory fitness, reduce cardiovascular and diabetic risk beyond that produced by weight reduction alone, and may reduce loss of muscle mass associated with diet. And this is some classification of intensity of physical activities. You can see the sedentary, light, moderate, and vigorous intensity exercises. As usually we need at least moderate exercises like brisk walking, gentle swimming, dancing, gardening, house carrying, moving moderate loads less than 20 kilograms. These are activities which are at intensity that requires some effort but allow a conversation to be held. And this should be also, if we are going to vigorous exercises, we have to get some opinion from the indicated person. And this is the recommendation for physical activity recommended by American College of Sports Medicine. For maintaining health, we need 150 minutes per week exercises. It's 30 minutes per day for 5 days. And for prevention of weight gain, it needs 150 to 250 minutes per week. And promote clinically significant weight loss, it recommended as 225 to 420 minutes per week, at least 1 hour per day for 5 days. To prevention of weight gain after weight loss, it needs 200 to 300 minutes per week. And this is some advices we can give to our patient to increase daily activities. A patient should aim to increase daily activities with this.
skip skip
And this is behavioral change techniques. It's also mainly self-monitoring of behavior and progress, goal setting, stimulus control. I have to recognize and avoid triggers that prompt unbalanced eating, and cognitive structuring, problem solving also there. And psychological therapy-wise, we can educate patients on reducing stress and tension, such as by educate on muscle relaxation techniques, meditation. And I'm not going through the pharmacological therapy deeply. This is just to give us some idea. Usually, drugs are indicated when BMI is more than 25 or 25 with 1 or more obesity-related complications, and if BMI 30 or more without obesity-related complications. All currently approved weight loss drugs act as anorexians, with the exception of orlistat, which inhibit the absorption of dietary fat. And surgery, when considering surgery, bariatric surgery aims to reduce food intake by restricting gastric capacity and reducing uptake by reducing exposure to the small bowel absorptive area. There are indications for people age group from 18 to 65 years if there is BMI 35 or more, even when there are no medical problems. And second indication is BMI 30 or more with more than 1 or more than 1 obesity-related comorbidities, such as this given list: type 2 DM, hypertension, dyslipidemia, OSA, asthma, debilitating arthritis, debilitating, and impaired quality of life, or non-alcoholic fatty liver disease. And in follow-up and reassessment of this patient should be followed up initially 1 month after, and then we usually should be followed up for 3 months, and then 3 months to 6 months accordingly. If there are complications, we have to assess very frequently, and set also encourage self-monitoring of weight. And this is regarding treatment of diabetes in obese patient. As physicians, we should, in obese patients, we should start with weight lossing agents like metformin, GLP-1 analogs, DPP inhibitors, SGLT2 inhibitors, and should avoid weight gaining medications such as sulfonylureas or thiazolidine. And when treating with patients for hypertension in patients with diabetes and obesity, it is better to use ACI, ARB or calcium channel blockers rather than beta blockers. And this is some points regarding management of other medical conditions. Women with BMI more than 30 or more than 25 with comorbidities, other contraceptive methods are prepared over injectable medications like DNPA. And steroid-sparing drugs should be considered when possible in the treatment of chronic inflammatory conditions. And weight neutral antipsychotics should be used when indicated. And consider weight gain potential in choosing antiepileptics. And monitoring the waist circumference of patients on antiretroviral therapy due to unavoidable weight gain and fat redistribution. Also, symptomatic weight loss medications such as phentermine, diethylpropionine in patients with uncontrolled hypertension or heart disease should be avoided. This is as family physicians, we encounter children also. So we have to educate the parents and children regarding prevention and obesity.
Next, Secretary, next slide.
Yes, it's all, madam. This is take home message.
Okay. So thank you very much for Suboda for preparing this presentation with the guideline information, and I know that you have done a good job. So thank you. And what I really need is here, being the first contact care family physicians with the training. So you have to focus about whenever a obesity patient comes, not only at the time that they come and say, doctor, I need some weight reduction, but also whenever they come with other illnesses as priority, but you have to look for the obesity and identify that it's the most important, the duty for you all to recognize obese patients whenever incidental presentation as well as when they purposely come to get the treatment as equally as well, right? Because they here, so in case of the what our need is, being the trained family physician is need here, because to assess the obesity, to categorize it to the obesity guidelines in which grade the patient is, and as well as to find out from the history what is the the comorbidities after confirming the obesity. What are the comorbidities, or what are the risk factors that patient is having, any underlying possible but the very firstly, we have to find out any underlying reason for this patient's weight gain. Out of all, although the poor dietary pattern and the lifestyle, the gaps are there, but there are so many, the patients can come with some pathological disease inside for them to get this obesity, right? So because of that, you always have to think about, the possible, the common, the other pathological conditions which can give them this obesity, right? But among us it's commonly the thyroid dysfunction, as well as in the drugs and the genetic problems, family, right, family history, and there are the food pattern are the common things. But still we have provided you the other possible the underlying the causes. So that is your duty to identify any other risk, any other cause behind to this patient to get the obese, right? And then on examination, you can confirm the obesity by the measurement of BMI, and as well as the the reliably by the waist hip circumference ratio. And then look for other possible comorbidities with this, like, the insulin resistance. Mostly not the diabetes, they are pre-diabetic, right? Mostly. So look for acanthosis and other possible, the xanthelasma or whatever it is. So, and the thyroid function, and look for the appropriate examination to detect any possible signs to find out any underlying cause is there for this particular patient to get the obesity, because which can be corrected easily, other than the letting the patient to the suffering with this obesity, right? So that is your very good, you should be motivated for that, to detect it from the history, confirm it from the exclusion from the examination, right? Then counseling is very important. And the problem here is, the mostly the ultimately the lipids, the starch or whatever it is, will be converted into the toxic fatty acids, right? The toxic fatty acid is the trans fat, right? Trans fatty acids, not the cis fatty acids. There are two types of fatty acids, trans and cis. So most of the unhealthy diet, the content of fat or starch will be converted into finally the trans fatty acids, which are the nastiest, the chemical nastiest agent to the give those the almost all the risk factors that emerge from the obesity, like the malignancies, organ damages, organ diseases, right? Most of the things which if they irreversibly damaged our organs inside the body. So because of that, so you must know what are the food products that have the trans fats, they finally make into the trans fats, and the good the cis fatty acids. So because of that, you have to have that knowledge. Usually the bakery products with lot of margarine with heating, and as well as the rice, lot of rice, and as well as the some milk, dairy products all have the high calories, and but the fats in it will be, and the starch will be in excess, will be turned into the trans fatty acids, which is very, very nasty, right? And as well as the cis fatty acids, coming from vegetable diets, right? And vegetable proteins, okay? And fruits and the salads. That is the common thing. Even though this is not our subject, but still, since the nutrition service is not available as such as widely, so you have to think of giving a diet treat or encouragement. Reinforcement need to be done, because once you keep telling only, the brain will get used to that, and brain will come to the point to implement the program. So because that is not a patient's problem, if the patient is not compliant enough, you have to keep motivating, in which some ways there are different ways to do that. So you have to identify that particular candidate and get them down in the friendly way by establishing
Can't hear, madam.
microvascular disease. So because of that, the case, even though you look simple and obesity, but I know for sure that you all are, the missing lot of obese patients because of, the no proper, the acute, you have to look for that, not wait till patient comes to you. And the second thing is identify the possible underlying cause which can be corrected, right, by getting correct history and the examination and doing the correct investigation. And the third thing is, the once you identify, that is not only the correction of the high calorie diet to the low calorie diet, but the treat for the underlying cause, and monitoring is very important, right? So you have to take the patient out of risk by treating to the underlying possible cause if you detect it. So even though majority of the cases are the high calorie diet intake, we know, but you have to look for the underlying possible causes for the correction and the change the behavior by the keep the getting more frequent in the consultations with you all, not like as the as the other, the diseases, but here you have to make up your very good rapport with the patient in order to give him a relief with weight monitoring. That patient will be, understand that patient is going to get, the progress. So because of that, close, the monitoring and consultation is very, very important, right? So, and the guideline management is very important, right? As well as what are the types of, the calorie loss that we have to recommend for the type, according to the types of obesity. And, the always don't talk whenever you are getting a cases in the exam. Definitely, it's a must for any component, MCQ, and as well as OSCE, and, the other computer-based OSCE as well. So because of that, you have to be very much ready for the exam purpose, as well as if you practice it now itself, accordingly, then you will be automatically get the skill into your mind. And same way, like practice, 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 then only your brain will identify, the treating the patient. So like the same way that you're going to motivate your obese patient for the dietary manipulation and the lifestyle exercises. That is not easy task, but if you keep close with them and monitoring them in a friendly manner, you can. It's a real, the good, the duty for the patient, family, and to the nation. So please don't, ignore the obese patients without, so until patient comes to you. So identify them and start your program with the patient in order to give them a better, the healthy life. So thank you so much for your the patience. And again, thanks must go to Dr. Suboda Registrar, and others also join from primary care groups, which we have done capacity building programs from, because last moment only I sent this link. So sorry for them. But anyway, I saw that few of them have joined. So registrars and SARS, whoever. And my special thanks to Dr. Fasana, my acting consultant. She's always supporting the trainees to make these preparations, presentations, and giving the knowledge and skills. So thank you so much. And Prabhat for giving us the assistance for the this technology. So any questions you can discuss now. Thank you. And I am taking this opportunity as an advantage to, tell others primary care capacity building program doctors, if you all have joined, please know that we will send you the Google, the link through this in order to get your our associate membership, which you are getting so much of, the benefits in future with CPD programs as well as the annual, the academic sessions. So kindly please join and tell your, convey the message to your diploma holders in family medicine as well. Thank you.
Thank you very much, madam.
Thank you very much, madam, for your guidance and training.